premise of the article, is a review of decentralized, digitized clinical trials, which really has been it's been a booming uh, field over the last few years, particularly since the COVID pandemic. Hello, my name is David Harmon. I am a cardiology fellow here at the Mayo Clinic, and I am the primary author working with Dr. Noseworthy and Dr. Shaoxi Yao on a review article titled The Digitization and Decentralization of Clinical Trials, published in the Mayo Clinic Proceedings coming up here in October.
Hi, Peter Noseworthy, Cardiac Electrophysiologist at Mayo Clinic in Rochester, Minnesota. Maybe you can summarize the key points that we made in the article as a starting point.
Sure. No, I think that'd be great. So, we had the huge boom of telehealth and telemedicine and started seeing patients more virtually, and clinical trials kind of followed in that suit. So we really see now that a lot of different institutions, including the Mayo Clinic, has been digitizing and decentralizing clinical trials so then patients can participate even from the comfort of their own home. I think it's very interesting, particularly in this field, because there's a whole spectrum of digitized, decentralized clinical trials, anywhere from just simply digitizing consent forms all the way to having entirely virtual trials where patients don't even have to interact with the physician. They can participate entirely from home. These digital and decentralized trials are new, they're here to stay, and I think how we work with them going on in the future is going to be very important.
Yeah. I wonder if this might have been happening anyway. The advent of digital tools at the disposal of clinicians, the ability to get pragmatic event adjudication through the electronic health record, patient-reported outcomes. There's been sort of a change very slowly over time. It was definitely, certainly accelerated by the pandemic. Maybe you can give us some bullet points on some of the examples of the trials that we've been able to do at Mayo Clinic.
Sure. So I think one of the interesting trials is one called the EAGLE study, where we had a digital notification that would go out to providers taking care of patients within the community. And anytime an electrocardiogram was ordered, it would be processed through one of our convolutional neural networks that would then screen the patient for potential heart failure or left ventricular systolic dysfunction, meaning that their ejection fraction was below or equal to 40%, which normal is 45 or 55 to 65%. Now, this trial was interesting in that we were able to expedite screening echocardiograms for patients who were at risk or at elevated risk for left ventricular systolic dysfunction, and we were able to find that in the community, this actually expedited this diagnosis in folks with asymptomatic disease, which is really a huge, because some folks go on for years, and then by the time they're symptomatic, they have really severe heart failure and manifestations that are almost irreversible. In some cases, they are irreversible. And so by this new screening attempt using non-invasive technology, using an AI-based ECG that is a point-of-care test in the doctor's office, then we could inform clinicians that some patients may be at higher risk than is visibly seen by the ECG and by the manual interpretation. The other big breakthrough study was the BEAGLE trial, which used the AI ECG in a slightly different way. So we used the AI ECG running 12-lead ECGs through our convolutional neural network to detect patients' risk for silent atrial fibrillation or undiagnosed atrial fibrillation, even while in sinus rhythm. And I thought this was a huge game changer, because we sent out mobile ECG wearable Holter monitors that patients would wear at home, but we sent this out to patients who are at risk not only of silent atrial fibrillation by our AI ECG, but also who this would change practice in providing them with anticoagulation because they are placed at elevated risk of a stroke from silent atrial fibrillation. Many of these patients, the first sign of atrial fibrillation, unfortunately, is a stroke or some other thromboembolic event. And so by screening for this high-risk population, we're actually able to diagnose successfully atrial fibrillation that is otherwise silent and asymptomatic in many of these patients until they have some major event. And this is a big practice change as well, mostly because these patients go under the radar frequently in the clinical practice, and our current screening tools don't have this type of evaluation, this type of proactive evaluation that we did with the BEAGLE trial.
Yeah. A few other interesting points about those two studies is EAGLE was randomizing at the level of care teams, randomizing the clinicians taking care of patients to either get the AI or not get the AI. Do you think this kind of model holds some promise in that regard, and if so, how?
Absolutely. So I think the the big takeaways from this are we're able to allow these patients to participate from their home environment or from their primary care environment. They didn't need some third or fourth referral to a super subspecialist within a field. They're able to go to their primary care doctor and come away with a potential screening for, heart failure, or they're able to get a single 12-lead ECG and then qualify for a study where they're able to have prolonged screening for atrial fibrillation at home. And I think this will be really important, especially for at-risk communities who only have access to a primary care provider or may have limited resources, maybe not able to get an echocardiogram without a referral or without a provocative diagnosis or risk factor. And so I think this will help expedite care, particularly in these marginalized communities. I think the other big factor is being able to participate from the home environment is huge. You see a lot of folks not able to participate in clinical trials because travel is a barrier, or they live out in the rural areas, or they don't have transportation simply that's available to them. And so these trials overcome that and are able to allow not only diagnosis but at home, but also participation from their own homes, which I think is a very important gap that is being bridged by this. I think the next big step, though, will be ensuring that this is affordable and accessible to these folks who are participating, because not everybody has internet, even in this day and age. Not everybody has, digital devices like Apple Watches or iPhones or things like that. So some of these novel digital trials will have to bear in mind that some of these patients may not have access to, higher levels of digital technologies. And so we might have to meet them in the middle somewhere, which I think we did well with the BEAGLE trial, using our own technology and sending it to the patient.
In a sense, these are testing interventions that are implementation of technologies at scale at sites outside of a single academic medical center. So in a sense, if they're successful, they provide a model for patient care delivery at scale, which I think is really an interesting, promising aspect of this. I think for more details, the listeners will have to log into Mayo Clinic Proceedings and read the article. But thanks a lot for joining us.
Yeah, thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.